Hi, everyone. Welcome to our latest version of the AAOA Journal Club. I'm here with Dr. DeMason to talk about a few of the latest and greatest articles in the literature related to uh, kind of general ENT and otolaryngologic allergy. So let's get started. So, first up, I actually found this article in Laryngoscope last month, and I thought it was a really nice review and kind of, I liked it because it was, which I'll get into, it's made for ENTs by ENTs. Okay. So, this is a expert consensus statement on refractory chronic cough, which is kind of something that hits all our offices, right? And sometimes those patients can give us a run for our money. So it was a study or a statement put out through Hopkins. They coordinated it. And basically, they got approval for it by the American Bronchoesophagological Association, right? So they followed the Academy guidelines for expert, it was like an Academy manual that we have for expert consensus statement development. And they had kind of a chair of the committee, an assistant chair, and then they had 11 fellowship trained laryngologists who were deemed experts in the field of refractory cough on the voting panel. So they put out these Delphi statements and they went through, rounds of voting, and they basically came up with 27 statements that met consensus in different categories for refractory chronic cough. And then they had, I believe, six that did not. So I just kind of wanted to review, kind of to get organized in our heads, kind of when dealing with these patients, kind of what the experts are saying. Okay. Um, so when they uh, define it, right, a lot of the big national academies define chronic refractory cough as persistent for greater than 8 weeks in adults. And then you've ruled out what I call the three pipes, right? You've ruled out a pulmonary source, a gastric source, and you've rolled up an upper airway source like chronic sinusitis, postnasal drip, right? So the other consensus statement is that you cannot guarantee that people have had a complete workup for all of those things, right? So you want to make sure that the workup has been complete for all those things before deeming it or defining it as refractory chronic cough. The next set of consensus statements came from the pathophysiology, right? And so we know about the peripheral hypersensitization as well as potentially a central hypersensitization of the cough reflex. And then you will get a hypersensitization resulting in a provocable cough with something that shouldn't be like a noxious chemical or mechanical stimuli. So that, again, in terms of the definition of the pathophysiology, reached consensus, okay? And we don't know exactly why, and that's a consensus. And then when we talked about the workup, they give us a nice summary of what they deem as an appropriate workup from the pulmonary standpoint, including right pulmonary function testing, acid suppression trials, and what adequate suppression trial means. Okay. And that means 2 to 3 months is an adequate acid suppression trial, and even which medications. Okay. They also talk about alginate therapy, and then they talk about the ruling out of medications like ACE inhibitors, ARBs, as well as the evaluation of the upper, right, upper airway in terms of sinonasal stuff. And then they talk about symptomatology, and they had a couple of consensuses on that, which was, things that can lead to refractory chronic cough, but not necessarily are things that haven't been treated. It means you did treat it, but that might have been the inciting event. And, knowing how much it impacts them will tell you, kind of guide you into how aggressive you need to be in terms of the treatment. So then we talk about two major kind of avenues that have been used for the treatment of refractory chronic cough, which is the neuromodulators, which again have a role, but the regimens are all over the place. And that's really the consensus, is that it's all over the place. And they have side effect profiles that we need to be cognizant of. The newer kid on the block, right, is superior laryngeal nerve blocks. And that has also not really necessarily been super standardized in terms of what the medication dosing and regimen is, but it has been shown to be helpful as an option. And then behavioral cough suppression therapy, it's low risk and may be beneficial. When we talk about vocal cord augmentation, again, it's really for people who have that concomitant glottic insufficiency, and then Botox can be considered. All right. And then the overall treatment approaches, it kind of summarizes what we know, right? Which it's patient specific, shared decision making, keep your toolbox broad. So here are the things that didn't reach consensus. And these are things like trigger point injections, um, the behavioral treatments for things where there is really something more structural like glottic insufficiency or muscle tension dysphonia that didn't reach consensus. When we talk about superiority of neuromodulators versus superior laryngeal nerve block, one being superior to the other did not reach consensus. Okay, and that I thought was important to consider. And the idea is when we talk about alginates, it's low risk, but again, it's part of the decision making, but it's not necessarily a firm like kind of treatment trial that you want to do. So those were kind of the summary, but I liked it in terms of the clarification, right, of what the workup looks like, what the definition is, when you can really call it, and then what is really the experts are telling you can be in your toolbox. So if you guys want to ever pull up the paper, it gives a really nice, I gave like a kind of 30,000-foot view, but it goes into a nice detail about the summary of these medications or these treatment options and more specifics on the workup. So if anybody wants to pull it and read it. What were your thoughts on it, Dr. DeMason?
Yeah, I think it's great. It kind of summarizes what I've been thinking that I didn't have a neuromodulator that I could find was better than the others.
Yeah.
Um, I don't do superior laryngeal nerve blocks, but because I'm at an academic institution, but definitely think it's something I would try if I was in private practice where I didn't have someone readily available.
Yeah, absolutely. I actually think it's a great option. It's not like a technical, for ENTs who are in the neck and know the anatomy very well, it's not technically hard to learn. And in fact, at our Explorers course, we do teach it readily to our AAOA members. And this year's Explorers course will actually have a focus on laryngology. So I can be very sure and confident that that'll be discussed. So um, it was a nice paper, kind of given the expert state of the art latest stuff on an issue, like I said, that kind of gives us some frustration in the office. All right. You're up next, Dr. DeMason.
All right, so we're going to talk about this article that came out this year in the White Journal. It's on the association between allergic rhinitis, eosinophilic inflammation, and postoperative recurrence of nasal polyps. So next slide. So this is a single institution tertiary referral center that was a retrospective review from 5 years. They looked at all patients who had endoscopic sinus surgery by a senior surgical team. They then looked at if the patient had had allergy testing, and they diagnosed allergic rhinitis if the patient had both clinical symptoms and at least one objective test that could be blood or prick testing. Um, then the tissue from the sinus surgery, they did look at eosinophilic counts, and then they also did blood eosinophilic counts as well. Um, they also looked at patients' recurrence in 3 years. So they measured a recurrence as at least 2 months of symptoms plus endoscopic or CT findings of recurrence that didn't respond to antibiotics or steroids. The other thing I think is important to note is they excluded smoking history, and then anyone who had had systemic steroids, antibiotics, or immune modulator medications within a month of surgery. So I do think that probably took out a lot of people. But they ended up having over 600 patients. 200 of them had allergic rhinitis. Right off the bat, they noticed that those patients were more likely to have prior surgery as well as comorbid asthma. So you can go to the next slide. The first table again is showing that the patients are more likely with allergic rhinitis to have asthma and prior surgeries. And they also noticed that they had a shorter duration and increased rate of recurrence post-op. The figure on the right is showing the eosinophilic count in the specimen was higher in those with allergic rhinitis compared to non. However, blood eosinophilic counts did not differ between patients. And then table 2 on the lower left is showing that during follow-up, patients who had recurrence had a higher prevalence of allergic rhinitis and higher elevated peripheral and tissue eosinophil levels and a higher prior surgery. No surprise. Next slide. So then they also did a regression analysis, and they did find that allergic rhinitis was an independent predictor of recurrence, and that included all models when they excluded demographics, clinical characteristic, eosinophilia, and radiological scores. Figure 2, which is on the lower left, is a Kaplan-Meier survival analysis. And what you can see on that is that allergic rhinitis patients had an earlier onset and a higher reduced recurrence rate of survival. And then the next table, again, they adjusted for tissue eosinophilia counts and radiological severity, and they still found that allergic rhinitis was a significant predictor of recurrence. Once they got rid of the eosinophilia count, they did notice that that effect was smaller, but still significant. And then the figure 3 shows that a higher tissue eosinophilic burden independently associated with recurrence. You can go to the next slide. So they did, of course, only do one geographic area in China, and it is a single surgeon. The other thing to note is they didn't look at a specific allergy. They looked at just if you're allergic to any allergy specifically. But overall, they did find that patients with chronic rhinosinusitis with nasal polyps who did have allergic rhinitis did have that elevated tissue eosinophilia, and that allergic rhinitis was an independent predictor of early relapse in these patients. And so it's possible that it's a chicken or an egg problem, right? So who knows if the allergic rhinitis caused the eosinophilic inflammation or vice versa, right? But anyway, more studies need to be done for treatment, but this is definitely important when you're thinking about patients with nasal polyps that you may want to be more aggressive with the allergic rhinitis patients.
I think this supports a growing body of literature on things you can use to kind of predict endotype, right? Outside of,
Right.
right, these like high-end analyses of tissue.
Yeah.
So one of them that's a clinical indicator is environmental allergies, and that kind of puts you into the prognosis category of, what you can tell the patient about their prognosis. So I definitely think it was helpful. Um, the other thing, though, we always keep in mind is that internationally, right, like endotype proportionality can vary.
Mhm.
And this, you said this was out of China and it was a single surgeon. So that I thought was a little bit of a limiting factor to the study, but still useful clinical information either way.
Yeah, it'd be nice to see, areas in our practices, but I do
Sure.
think it was a really well done study.
Yes. Yes,
Yeah.
absolutely. The methodology was very solid. All right. So, on a similar vein, I found another study that came out very recently, was accepted last month in Laryngoscope. on chronic sinusitis with nasal polyps and eosinophilia. So increasingly, right, when we're trying to endotype patients with regard to their sinusitis to see if they're, one for prognostic value, two to see if they're candidates for biologics, things like that. A lot of us have been requesting eosinophil counts in tissue specimens, whether it's per high power field or percent of inflammatory tissue. To kind of give us more strength in terms of endotyping the patients. And a lot of us in the same vein like perioperative steroids for our polyp cases because it helps visualization and decreases bleeding and kind of makes your job a bit easier and gives us an opportunity when we have that better visualization, right, to be more thorough and do a better job, right? So here's the rub, right? Like if you're giving systemic steroids, does it affect what you're pulling up in the biopsies when you take the specimens in the OR? So this is a systematic review with a meta-analysis on the effect of those perioperative or preoperative, excuse me, systemic steroids on tissue eosinophils, okay? So methodology, and this is a study out of Thailand, by the way. This study followed, the usual PRISMA statement and was in the Prospero database for systematic review and meta-analysis. And it cites specifically adults, okay? And it pulled these 17 papers with regards to evaluating tissue eosinophils with preoperative steroids. And it further categorized low dose steroids versus medium to high dose steroids. And they separated that by less than 30 milligrams of prednisone equivalent a day or less than 0.5 milligrams per kilogram. All right. And then they divided what they defined as short duration versus long duration is less than or equal to 7 days or greater than 7 days. So they also did bias assessments of the different studies, and in total there was 930 patients. So a nice large number of patients. Five of the papers were randomized controlled trials. 8 were cohort or retro studies, and then 4 were pre-post studies. And they were able to do meta-analysis with 9 of the studies, and they were able to subgroup, like I said, based on dosing and duration with some of the studies as well. So when we look here, this is the effect on eosinophil count per high power field. And so you can see based on the forest plot that there's a significant reduction in eosinophils per high power field with when you just lump together all preoperative steroids. Okay. And then further, when it's separated into medium high dose, low dose long duration, or medium high dose long duration, all of them created significantly lower eosinophil counts. So it's going to affect, right, the information you're getting. The one where it didn't, I'm sorry it cut off here, but it was the top one, which is low dose, short duration preoperative steroids. So less than 30 milligrams and less than 7 days did not necessarily sway it enough to affect the forest plot. Okay. And I think a lot of us, I mean, when I talk to my colleagues, there's a huge range of what people are doing in terms of preoperative steroids or, treatment trials of steroids. So I think the subgroup analysis was really helpful for me as a clinician to know, what's going to affect what the tissue I'm getting versus not. Okay, this was the effect of preoperative on percentage of inflammatory tissue. Different places will display how they're assessing eosinophilia in the tissue differently. And this again shows significant reduction in the meta-analysis. So there's a high level of evidence that suggests that preoperative steroids lower tissue eosinophilia. At the same time, this has been our workhorse in terms of preoperative management of polyps to kind of help ease, surgery. But we're using this as a tool. So the other option is, right, if you're using low dose short duration, you have less effect on the tissue eosinophils. So the question remains, like, what are we going to do? So what what have you been doing lately, Dr. DeMason, with your polyp cases?
Yeah, I mean, I still give a little bit higher than 30 milligrams, because the question this doesn't answer is when is bleeding, at what dose is bleeding controlled, right?
Right, right. Yeah,
So, and I just don't know if a short dose or small dose short course is going
yeah,
to do it, but that would be a great study, of course, to see.
sure. I have heard of surgeons increasingly use TXA in
Mhm.
the OR for polyp cases in
Yeah,
an effort to reduce steroid burden as well. So that's been out there as well. So I'm curious to see, based on this, our increased dependence on tissue eosinophilia and our kind of increased stewardship on steroids, kind of where things shift. So I thought it was a very thought-provoking and well done study.
yeah, I agree. All right, so the last one is looking at all the systemic reviews and meta-analysis of sublingual immunotherapy for allergic rhinitis. Next slide. So they looked at, all the review articles that are out there, um, removed any duplicates or irrelevant trials or um, any that didn't seem, that didn't meet inclusion criteria, and found 20 total. 13 were in English and 7 were in Chinese. All of them had a control group. They then looked at this corrected converted area, that looked at how many of these reviews had included the same articles, and there was a modest overlap in that. Next slide. And so this is a little bit busy, but essentially it's showing, they looked at the methodology quality, using this Amstar 2 checklist that has a lot of, kind of basic, did they talk about inclusion and exclusion criteria? And they found that actually most were low quality, which is interesting. And then they also looked at the reporting quality, which has some of the very similar kind of checklist, the Prisma 2020 checklist, which includes similar things, like inclusion and exclusion criteria. And they found that most were considered about moderate quality on that. So next slide. Good news is they showed that almost all of them had low risk of bias, so at least that's good. So the bottom kind of pyramid is showing kind of the quality, and overall they rated 7 as high quality, 19 as moderate, 13 as low. A lot of the quality had to do with the heterogeneity of the dosing of the slit. There are a lot of different dosing protocols, different timing, duration. So it was really hard to compare essentially. But from there, they did make some kind of conclusions. So if you go to the next slide, I think this was, to me, the most kind of interesting finding is, they looked at symptom score. So 18 of them looked at symptoms versus medications. And interesting, what they found is that slit, and it makes sense, but slit had a reduction of medication use before patients actually saw a symptom reduction. And so overall, there was improved symptom scores compared to placebo. However, really, they found that the medication reduction was the main takeaway. And so something to keep in mind when you're counseling patients, that it's about getting off other medications. So the right did show that it had a high kind of tolerability with a low systemic symptoms. So they didn't have any anaphylaxis. The most common adverse event was itching in the mouth, so oral findings, and that was between 5 to 14% of patients. And then if you look at the bottom, they did look at kind of the IgG and IgE levels. Only 8 studies looked at that, and there was no significant reduction in IgE levels. They did find elevated IgG levels in post-slit patients. And then there weren't a ton of papers kind of comparing tablets versus drops, but the ones that did noted that there was better compliance with slit tablets. However, there was more local irritation with the tablets than the drops. So keeping that in mind with patients, what is more important to them, and of course what you're treating. And then quality of life, they did find a significant improvement in patients' quality of life. This even included some things that we don't always think about, but emotional functioning, daily activities, and nasoocular discomfort. So you can go to the next slide. In summary, there were um, studies showing the benefits of slit. However, there was a lot of varying methodology quality in the studies. This is largely due to the heterogeneity among the studies, so the allergies that were treated and the dosing that was used. However, it kind of all of them did find that slit improves symptoms, reduces medication use, and is generally acceptable.
Wonderful. I'm so curious to see that as we get hopefully more FDA approved
Yeah.
tablets and it becomes more readily available to the general population, kind of how the quality of the studies improves and how we get some more robust kind of evidence. But I do think it is the way the trends are going.
Yeah. This is a great plug for the AAOA Foundation grants. If anyone's interested in
Yeah.
split research, there is funding for that.
Yep, absolutely. And we've always tried to be kind of the on the frontier of what's going on at the AAOA with SLIT. And ENTs have been much quicker adopters of sublingual immunotherapy compared to general allergists. And we're very proud of that because I think it does do a service to the patients.
Mhm.
Wonderful. Well, that was a great another
Yeah.
Journal Club episode. Thanks for joining. Hopefully, we'll see you guys next time and feel free to kind of post any feedback.